Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Welcome to our first to this year musculoskeletal ultrasound course. Tonight is the first of 2 nights for the basic course. And that is gonna be covering a lot of the basics in musculoskeletal ultrasound. Before introducing any more of this meeting that is being organized by Infomed and run through Emirates Rheumatology Academy, I'd like to thank all of the speakers for their great efforts in joining us today, and welcome all of the attendees, and hope to have a Q&A at the end of each session today. It's my pleasure and honor to always introduce my brother, Professor Ahmed Abu Jamal, who is the director of the RLAR Musculoskeletal Ultrasound Group. He's a consultant rheumatologist at Dr. Salman Habib Hospital. He's a professor of rheumatology at Al-Azhar University, Cairo, Egypt. He's a musculoskeletal teacher. He participated as an organizer, speaker, instructor, national, regional, international rheumatology conferences, and is an active member of the GRAPPA network, and also Emirates Osteoporosis Society. He's has also an active member of the ACR and has many, as you know, researches and articles published in national and international journals. So without further ado, my brother, Professor Ahmed Abu Jamal, the floor is yours. Thank you very much.
Okay, thanks, Dr. Walid. And we really appreciate your effort in supporting education and learning, especially in the subject of musculoskeletal ultrasound. And from here, actually, I really thank the effort done by the ERA to increase the knowledge and training regarding the important subject like the musculoskeletal ultrasound. And for sure, I would like to thank all the faculty joining this project for their already commitment to train, educate, and learn all the rheumatology fellows over the world. And from here, actually, the best example or words to be memorized here as a start, the famous words from the Prophet Muhammad ﷺ is stating that deeds are only with intentions, and every person will have only what they intended. And actually, there is no a beautiful and bigger intention, bigger than the intention to educate people and learning process. My subject will cover the basics of the ultrasound. I'll try to move between some history, how the ultrasound is developed, to the some basics already essentially to understand how the ultrasound it works. And I'll go through to the light physics just to make highlights regarding the basics of the ultrasound physics and physiology. This is my disclosure and most related to this presentation. Before starting, and today you are speaking about the basics of the musculoskeletal ultrasound. And before starting, this is actually 3 important advices regarding the ultrasound for all beginners who try to understand and utilize ultrasound in the process of rheumatology management and following up patients with the ultrasound. It's very important to understand that ultrasound is not coming to replace your clinical skills. Ultrasound, yes, it's important, but it's coming mainly to support and increase the sensitivity of your clinical skills and the clinical decision. The second advice that ultrasound is not giving you the diagnosis. Ultrasound just help you to collect a more deeper information in the joints that lets you understand the happening pathology, and this also could aid the diagnosis based on the clinical scenario and other supporting history, the clinical assessment, and lab. The third advice that ultrasound is not coming to decide which management is important to your patients, but with ultrasound you can assess your patients, you can guide your treatment efficiently and see the clinical response with your eyes, and also you can convince your patients about your approach in the management of different types of arthritis. This is actually my advice I always giving to the juniors and fellows at the start of the training and learning process of the musculoskeletal ultrasound. Moving to my agenda today, it will be about the history, as I said, for ultrasound, and moving to some principles of the ultrasound. The first, we'll start with the history of ultrasound. Who's responsible, or whose we can say that I invented the ultrasound? To answer this question, you can imagine that ultrasound passes through different steps. The first one comes from Italy, from Spallanzani Lazzaro, which is a known physiologist, professor of physiology, in 1729 to 1799. He discovered what is the first description or first idea regarding the echo or the ultrasound, and defined what is called the echolocation by a famous experiment. I think all of us knowing this, that already he brought owls in his lab and tried to let them move in a dark room, and he found that with absence of light, these owls cannot fly and cannot move accurately in the absence of light. While once he replaced these owls with the pads, he found that these pads can fly accurately and avoid to be hit by any wires in the found from the hanging from the ceiling, which means that there is another mechanism that pads can use it to define the actual location. And at that time, he defines this as an echo location based on the sound. A second more important step, which is the piezoelectric effect, which is already defining the ability to introduce or reduce the ultrasound waves in the lab, which already mean at this step coming to the French side from the brothers Pierre and Jacques Curie in 1877. Already the first one to discover the piezoelectric effect, and from this effect they invent the first transducer or probes, which already updated until to the ultrasound probes that I'm using nowadays. But going to the clinical application in medicine, after defining the echolocations and the piezoelectric effects producing the ultrasound probes, the first one who utilized the ultrasound in the medicines come from Austria, from a neurologist Karl Dosig in 1942, is the first one to utilize the ultrasound in clinical application, especially in defining and location of tumors. And he also is the first one who describes the joint echogenicity based on the ultrasound in 1958, who describes the attenuations and the acoustic reflections of the ultrasound waves from the articular and the pre-articular tissues, which already happening a long time ago in 1958. Coming to the first recorded image in the history for the human joints, this time from the British side, in the British Journal of Radiology in 1972. And the image at that time was published, try to differentiate between the aneurysm or cerebrophlebitis and the Baker cyst. And this indication is still valid till today. So the first ultrasound image in musculoskeletal tissue was reported for a Baker cyst behind the knee. While the synovitis first time to be described using ultrasound in 1978 as a trial defining the response of the yttrium-90 injection for chemical synovectomy to define the response of the yttrium radiation of the joint pre and post the injection in 1978. While erosions was the development of ultrasound first reported in 1988, and for the Doppler demonstration in the muscular ultrasound was first reported in 1994, with the first report using ultrasound guidance in 1981. But the biggest step for us as a rheumatologist was, I like to call it as a sonographic revolution, usually happens in the 20th century by starting the most important and still running program from the Euler almost over 22 years back, by start the training of the rheumatologist with the ultrasound used in musculoskeletal different indications and defining the level as basic, intermediate, and advanced. And since this introduction, we can found now almost an indication for the use of ultrasound in different rheumatological conditions and syndromes. Moving to the second part of this presentation, which is the principles of the ultrasound. And under the principles, we'll discuss some of the lovely physics. I'm sure that you will love it after the presentations, and the image setup and ultrasound terminology. As regards the physics, we'll discuss about the ultrasound concept, how the ultrasound machine is working, and three important definitions in the physics of ultrasound: the wavelength, frequency, and resolution. For us to understand the ultrasound machine, it is just for us as a computer connected with electric cable, which transforms the electric currents from the laptop or computer to the transducer. This transducer containing a crystal that has the ability to produce ultrasound waves under the piezoelectric effect. And this transducer transforms the electric wave to the biological or the ultrasound wave, which emits ultrasound in the same frequency in the same time towards the examined structure. Once the ultrasound wave reaches the target tissue, there is reflecting back different amount of the ultrasound waves with some resorption and some reflection. And at that time, the ultrasound probe behaves as a receiver to this reflecting back waves, and again transforms this reflecting back waves to electric current, which is finally translated through the computer to a gray or black and white image, giving us the image of the musculoskeletal structure that you are examining. It's a simple concept how the ultrasound machine works. The second part of the physics, which is an important definition, which is the wavelength, which is defined as the length of one complete cycle and the distance between two identical adjacent points in the consecutive waves, either from top to top or bottom to bottom. And the wavelength is a very important part in the resolution. We can say it in the coming slides. The second part is a frequency. Frequency is defined as the number of ultrasound waves per second, and is usually measured in hertz as 1 hertz. 1 hertz being one complete cycle per second. And based on the number of the waves in the second, we have different ranges of the ultrasound frequency. We have the low frequency with low number of ultrasound waves per second, medium frequency, and the high frequency ultrasound waves. And usually the range of ultrasound depends on the audibility, either audible or not. Usually the audible sounds lies between 20 hertz to 20 kilohertz, and the ultrasound is above 20 kilohertz, with diagnostic ultrasound usually start as 1 megahertz. Frequency, it is very important to memorize that with higher frequency, there is lower penetration of the ultrasound waves. That's why if you're going to examine a deeper structure, you have to rely on low frequency ultrasound wave to have good penetrations. But with good penetrations and lower frequency, you have a lower resolution, as always the resolution is connected to the higher frequency. So if you're going to examine a superficial structure, please rely on high frequency ultrasound waves. And if you're going to examine a deeper structure, you have to utilize lower frequencies. The fourth point, which is the resolution, which is an important parameter to have a good image or quality of image from ultrasound machine, which is defined as the ultrasound ability to discriminate between two closely spaced objects, or dots, as you are seeing here. As we have different dots here. If the ultrasound machine can define these two dots and receive them as a separate dots on the ultrasound screen, that means that this ultrasound machine have a good resolution. And the resolution of ultrasound image, we have two types of resolution based on the direction of the ultrasound wave and the relation between the two adjacent points. Either it is along the beam, so we call it as axial resolution, or across the beam, we call it as lateral resolution. And each point of them is important definition of the quality of the image. As regards the axial resolution, refers to the ability of the ultrasound system to differentiate two closely spaced points that usually lies in parallel to the ultrasound beam. As you can see here, this ultrasound, these 2 points are received by the ultrasound machine or wave as 2 different points, which means we have a good resolution. And usually the distance between the 2 points, if it is already related to the wave length, or usually less than the wave length, that means that we have already a good resolution, axial resolution of our ultrasound machine. In the other scenario, if these 2 points are received as 1 point, that means that at that time we have a bad axial resolution or low axial resolution of the ultrasound machine. And usually in turn, this can miss some pathological or physiological lesions inside your joint examined. For the lateral resolution, it is similar to the axial one, but this time the 2 points are already side by side from the ultrasound wave beam, and the ability of the ultrasound machine to display these small structures as 2 points in the screen is already defines the lateral resolution. Another important point in the lateral resolution that the behavior of the ultrasound wave after emission from the foot plate of the ultrasound probe, that we can see that this is usually the direction of the ultrasound waves. It comes in a converting angle and then divert back in both sides. So we have a point here. This is already at this point there is the nearest distance between the ultrasound wave, and actually here lies the best lateral resolution of the ultrasound machine. This is usually corresponding to the site of the what's called the focus, as if the focus already lying away from the 2 points. At that time, the ultrasound machine defines the 2 side-by-side points as 1 point in the ultrasound screen. And if it is lying away also from each other, received again as 1 point in the ultrasound screen. But if it is lies in exactly at the conversion points or the focus points, this is actually the best lateral resolution of the ultrasound machine. Moving to the image setup, which is very important part to have a good quality of image, you have to understand about gain, focus, depth, and isolation angle. And the gain usually depend on the brightness of the ultrasound image. With high gain, we have a brighter or more whiter images, and with low gain, we have more black images. And usually, for us, we are changing the gain based on the lesions that we are looking for. Sometimes we are looking for calcifications or bony pathology. It's better to have a lower gain so you can define the calcification easily. If you are going to define hypoechoic lesions or black lesions, better to go with the lower gain, with the higher gain as much as possible. Again, the focus, we have always to keep the focus at the area of interest, and in all machine you will find some 2 different patterns. The one defining the number of focus usually keeps the numbers as low as possible, and this image usually 1 or 2 focus is good to have the good lateral resolution at this level of the focus, and keep always the focus at the area of interest. The second point is the depth, where with the newer ultrasound machine, you can change the depth. You can screen up to even ½ centimeter with high frequency probe, and even you can scan up to 30 or 40 centimeter with some machines. So it usually depends on the depth of the structure that you are examining. You can increase the depth or increase the depth based on the area of interest. And we have what is called the isolation angle, which is the relation between the foot plate of the probe and the long axis of the examined structure, and usually try to keep this these 2 lines parallel as possible between the foot plate and long axis. So the ultrasound waves crossing the long axis of the examined structure in 90-degree angle, which makes sure that most of the ultrasound waves are reflected back to the ultrasound foot plate and gives actually a good image, good quality of image without any artifact, was called as anisotropy, as we are seeing here with an oblique angle. Already we have the ultrasound wave reflected back away from the ultrasound probe, so it's not received, which gives us a black image, we call it as anisotropy. Moving to the ultrasound terminology, we have to speak with ultrasound language to have already a good description of the area examined and to the lesion that we are seeing. Usually, we are relying on the ecotexture or echogenicity of the examined structure, and the ecotexture of the structure usually refers to the coarseness or homogeneity of the object, and homogeneity is a very important part to be described, especially if I examine a glandular structure like salivary gland, usually describing the homogeneity, either homogeneous or inhomogeneous. And also in some lesions like chronic synovitis, also it's important to describe the homogeneity in some points to differentiate also between some kinds of infections or chronic inflammatory synovitis. As we said, the echogenicity is the ability of the tissue to reflect ultrasound back. So the ultrasound probe receives some ultrasound waves, so we can see the structure, which refers is the echogenicity. And the higher the echogenicity of the tissue, the brighter appearance on the ultrasound image to appear more white. And the anechoic structure, which is already a structure that lack the internal reflectors, usually appears as homogeneous plaque. And the most famous example of the anechoic structure in physiological joints part is the hyaline cartilage. And in pathological, we have two famous examples of the anechoic or hypoechoic structures, the synovitis and joint effusion. Hypoechoic, as I said, which is the synovitis, which is a famous example of the inflammation. Isoechoic usually describe the structure in comparison to the surrounding tissues as isoechoic or hypoechoic or hyperechoic, and this actually again refer to the glandular lesion, especially in the salivary gland. We usually comparing the echogenicity of the gland with the different part of different pair of the other side of the gland, and also with the thyroid gland, because you have similar echogenicity should be always there. Hyperechoic structure, which already the brighter images that reflects most of the ultrasound wave, and the most famous example of this is of the bone, which reflects the higher part or most of the ultrasound wave emitted from the ultrasound probe. So in the echogenicity term, you are moving between the white on the most extreme right part of this image to the black on the extreme of the left. So you have to memorize, we have four terms as anechoic, hypoechoic, isoechoic, and hyperechoic, and you have to describe always the examined structure with one of these four terms based on the color variance from black to white. Another important part of the definition of ultrasound terminology, which is the type of the view, we have what's called transverse and longitudinal, based on the relation between of the lingual axis of the probe and the long axis or the foot plate of the probe. If it is parallel to each other, especially when examining a long axis structure, usually we call it as long axis or longitudinal view, and this time the structure appears as parallel line. The most famous example of this is already long axis view of the tendon. And if your ultrasound probe long axis of the foot plate is crossing the long axis of the examined structure, at that time we call it as short axis or transverse view, and this structure, the lines of the structure appear as dot. And again, the most famous example is the tendons. We'll move to the final part about the normal ultrasound definition of musculoskeletal tissues, started by the most famous, the tendon. Tendon usually, as we are looking for here, this is a specimen. We can see we have bagged fibers, dense collagen fibers passing already in one direction, usually appears as white lines in longitudinal assessment, with a very fine or minute hypoechoic background representing the connective tissue matrix, and this usually appears an hyperechoic structure in long axis. And in short axis, as we said before, in the type of the view, it appears an hypoechoic, but this time appears as dots with a minute or fine hypoechoic black background. For the muscles are abundant part of the containing water with big amounts, so it is usually appears as mostly hypoechoic with just fine fibers representing the perimysium and the muscle covering. And this is already muscle fascicles in long axis, and short axis, again, the muscle fascicles appears as short lines or dots with already an hypoechoic or black background. For the bone, which already a bright hyperechoic, and like to call it as the ideal white, because it's the most white structure you can see on the ultrasound probe, because of reflection of the huge part of the ultrasound wave with high acoustic impedance or difference between the tissues and the bone in reflection of ultrasound waves. And also bone itself is a big limitation of the ultrasound wave, as we cannot comment about any structure deeper to the bone cortex, but we can, with good sensitivity, we can define the cortical bone lesions as bone erosions, bone incisionophytes or osteophytes, and even some fissure fractures, especially in flat bones. But any lesions deeper to the bone cortex, it already cannot be defined or seen by the ultrasound wave. And again, also we have what is called the acoustic window. In some narrow situations that the bone itself blocks the ultrasound wave from examining any soft tissues that already lies anatomically in parallel or deeper to the bony structure. Moving forward to the cartilage, we have two types of cartilage in our body. The most famous for us is the hyaline cartilage, which usually appears, as we are seeing here, as a black hypoechoic or anechoic uniformly structure representing the hyaline cartilage, which can be differentiated from the fibrocartilage by a fibrocartilage containing some fibers, so it is more echogenic than the hyaline cartilage. And finally, we have the nerve. Nerve also appears as a fibrous structure, but it's more black in comparison to the fibers of the tendon. It appears as the nerve fascicles appear as an hypoechoic bands in linear in long axis as lines, and short axis appears as dots, small fascicles with hypoechoic background. So for my final slide about the home messages, so as a beginner for ultrasound training, you have to orient the physics of ultrasound wave, and you have to adjust your ultrasound machine setup to have a good quality of image. And finally, you have to memorize and describe all the structure that you are seeing in the ecoterms that we are mentioned. And this is my last slide. I'm finally, thank you. So we have to continue with our program today, and we have the second talk today was already from Dr. Nisreen. Dr. Nisreen is the lecturer of rheumatology, the physical medicine and rehabilitation, Suez-Canal University, Ismailia, Egypt. She's a rheumatology specialist in Health Shield Medical Center. She has a PhD degree in rheumatology from Suez-Canal University and have diploma of ultrasound examinations from San Antonio University, and she's already ULR certified ultrasound trainer and teaching already as undergraduate in the Suez-Canal University, and she's known speaker and trainer in the musculoskeletal ultrasound in the region. The talk of Dr. Nisreen about the pitfalls of the ultrasound image or artifacts, and we really thank Dr. Nisreen to be with us today. So without further delay, Dr. Nisreen, the floor is yours.
I'm very happy. I'm very pleased actually to be among my colleague in ERA, basic musculoskeletal ultrasound course. Just a second.
Or just keep it for the end. We have discussed all the questions after the last talk.
Yeah, as we all know, over the past 2 decades, an increasing number of rheumatologists have progressively incorporated the ultrasound in their diagnostic and in their clinic practice. Ultrasound is safe imaging, and it can give us a lot of information for diagnosis of many kinds of rheumatic and other diseases. But the problem is sometimes we have some missing of the diagnosis or false interpretation. That is because of what we have artifacts and we interpreted or misinterpreted it as a certain diagnosis. My objective today, we'll talk about the discussion a little bit about some basics. For sure, Dr. Ahmed covered all of them, but I will talk specifically about the sound waves and how it can be a source of artifacts, just to understand how the artifact could be. We'll talk about what is artifact and why it happened and how we can avoid them. So what is artifact? Artifact is any perturbation of the image, and it's not denoting or represent the real anatomic structure being evaluated. And it's maybe incorrect in many things. It may be incorrect in location or in size or the brightness. The structure can appear and it's not there in reality, or it's not there and we have it in the images. The source of or ultrasound systems, when it was created, it based on some assumption, which is the core principle of ultrasound in the manufacturer. But definitely this will be interrupted, or it's not the case in reality, and that's why we will go to some artifacts. The first one is ultrasound beam is narrow and has only a uniform width, which is not the case, and we will discuss later in the coming slides about it. The second one is attenuation of ultrasound is uniform, means it's all over the tissues, irrespective of the tissue type, it's the same attenuation and the same reduction of intensity of ultrasound waves. The third one is echoes from all depths are allowed to reach the transducer before the next ultrasound pulse to be emitted, which is not the case. The sound travel at a speed of 1,540 meters per second in the soft tissue, which is not the case, and we'll see there is some differences in the speed of ultrasound in different tissues according to the tissue. The fifth one, ultrasound wave can travel in a straight line directly and reflecting back to the transducer. We have completely another thing which will happen in reality. And the sixth one and last one is the amplitude of echo is directly related to reflectivity of the scanned object. Due to these concepts, which is not happened in reality, there is sometimes artifacts that's secondary to the error of many of these assumptions, as in beam characteristics or attenuation or multiple echo path or velocity. I will, as I told you, I will discuss some physical aspect of the sound, because this will help us to understand what is artifact. The first one is the sound travel at a speed of 1,540 in soft tissues, which is not the case. We have a difference in sound speed, which can be related to two factors. One of them is the stiffness of the tissue, and the second one is density. If I have a more solid tissue, it can increase the speed of ultrasound traveling through that tissue. Means that the ultrasound propagation in bone, it will be affecting, it will be more rapid or more faster than the air in the lung. The second one is the transducer is listening to echo. Means if I have short time of my echo to return back to the transducer, so this is equal to short listen. So the echo will appear near. Means I will see my structure very near to the transducer and very near to the screen. But if the transducer is listening to the echo away, so I will see it away and deep more than the reality. So the depth of the structure depends on the time interval between the transmitted echo and the received echo. Here in this example, I wanted to show you only what is near field roughly and what is far field. The near field is the roughly is the approximately upper 50% of our screen. And because you will hear it after some time, you know, during talking about the artifacts, and the far field is the approximately the lower 50% of our screen. If I have object here, like this ball is very near to my ultrasound transducer, so it will appear uppermost in my screen. We will consider here the skin of the patient, and this is the near field. That is if the object is very near to my ultrasound transducer. If it is away a little bit, so it will appear a little bit down in the screen. And it's not that the speed, the ultrasound is moved in one path. It's like it can be a multipath, and this sometimes can cause many kinds of artifacts. Like here, if I have a structure and I want to see it in the screen, sometimes there is many reflectors on the way of the path of the ultrasound. So part of the original echo return back to the transducer, and the other back will be reflected off and go to another second reflector in the path or in the beam or in the tissue I want to examine. So it will appear very delayed, and it will return back this echo to the transducer very, very delayed, and that's why it will be displayed deeper than the first one. What will happen if the sound little bit strike an object? There is many things can happen. If all the echo is reflected, so I will see it very white like this, we call it hyperechogenic. If no reflection at all, so it will be very black like that, so it's anechoic. If it is in the middle, so it will be like gray color according to the tissue. Sorry, I get stuck a little bit. We'll also talk about acoustic impedance. Acoustic impedance is very important concept. It is the resistance of the sound propagation as it passes through the tissue, and impedance depends on the density and property of the tissue and the velocity of the sound. We have different kinds of tissue. It's not only one tissue actually, which can be, the sound can be reflected or can refract it, but it depends on the which tissue is adjacent to another. So if I have air, it has a low acoustic impedance. If I have bone, that is the highest one. So this is also will affect the refraction or reflection of the sound. Sorry, I don't know, I get stuck sometimes. Okay, we'll talk also around about the beam. Ultrasound beam exit the transducer. It's the same width of the transducer and is composed of main ultrasound beam that narrow as it approaches the focal zone here. And this will be the maximum resolution as Dr. Ahmed just discussed. And as it approaches the focal zone, after that, it will widen and it will diverge. Any structure, very strong reflector that located outside the main beam, it can generate echoes detected, but it will not be detected by the side beams. It will be detected by the main beam. We have interaction between the sound and the tissues, and it depends for sure on the kind of the tissue and on the acoustic impedance of that tissue. So it can be reflected, it can be refracted according to the type of the tissue itself. One of the most important things which can affect the artifact is attenuation. And attenuation means that the intensity of the sound waves will be lower as it passes or travels through the tissue. It can be either by absorption, scattering, reflection, or dissipation. It means that the energy of that sound will be attenuated, but the issue is it will not be attenuated uniformly through the tissue. why the sound can be attenuated, that is if the sound is like traveling from two different tissues. The two different tissues have a slight difference in impedance. So this will lead to a changing of the angle of the beam. And this can cause little bit a phenomena, especially in the structures which is rounded or curved little bit, like a cyst or like a tendon Achilles, as we will see later. Also, a kind of attenuation can be due to reflection, and reflection can happen if I have two tissues with a large difference of acoustic impedance between these tissues, like the soft tissue and the bone, or the soft tissue and the air. This will help to have two artifacts, which is like mirror image artifact or reverberation artifact. Also, scattering, it's one of the modalities to attenuate the speed. It's another form of attenuation and occur when the sound waves encounter object with different acoustic impedance than the surrounding tissue, but it's very small to the size of the ultrasound wavelengths. Resolution, Dr. Ahmed is talking about it now. The resolution is very important, and it's the clarity of the image, and it's to discriminate the 2 points at a particular depth of the tissue, either vertically or horizontally. And we know that the linear probe is the best one to have a more clarity because of the contact between the lines of the sound waves, and it depends on the beam widths. It increases the resolution when the width of the beam narrows at the focal zone. Ultrasound beam is narrow in the focal zone, and now we can compare between these two pictures. This picture here, we can see the radial nerve, but here we cannot even calculate the radial nerve because of the blurring. Here, when I change to the focal point, I put on the focal point, or I put zooming on the structure I want to examine. Now I can clearly see the epineurium. I can measure the size of my nerve. Another kind of resolution, which is the axial resolution. And axial resolution, depending on the wavelength and the pulse length. And if we have more high frequency, we'll get more clear image. We'll start to talk about beam width artifact. And beam width artifact, actually, the ultrasound beam exits the transducer in the same width of the transducer, then narrow at the focal zone. So a high reflective object sometimes located outside in the widened beam area, in the divergent beam area, and they generate echo. We can see it in the machine as a small echoes, hyperechoic echoes appearing inside the cyst, mainly cyst, or if I have like here Baker cyst. In addition to that, there is some refraction of the sound waves at the boundary between the soft tissue and the fluid-filled structure, like the Baker cyst. So how to improve this image quality? It's by adjusting the image in the focal zone and put my transducer in the center of the object of interest. There is similar to that for side loop artifact, but little bit different ideas. We have a main beam coming from ultrasound, and we have side loops, which is weaker echoes, but it is strong enough to strike any reflective surface on the way of the beam, and it's reflected back to the transducer and appearing as if it's coming from the main beam. So we'll have also again some misplaced echo overlapping anechoic structure, and we can see it like a small thing like here. We can see some images here. Another artifact, which is depending on the impedance of the tissue and the difference of impedance and the difference of speed of ultrasound. If I have a needle and I wanted to inject my patient under guided ultrasound, and I have two tissues adjacent to each other, so I break with my needle. I have one tissue with a strong impedance. It has some reflection of the sound, and then I go through another one with low impedance. So it will appear very near to the transducer. So my needle will appear little bit toward the transducer or away from transducer, according to which tissues I enter first by my needle. Why that is happen more if my beam is perpendicular to the needle. So we'll try to change the angulation little bit, make it non-perpendicular little bit to see it clearly. We have another kind of artifact, which is posterior shadowing. And this will happen if the ultrasound beam encounter a very strongly attenuating structure, like a bone or like a calcifications, and the echoes returning from that structure will very high reflective actually structure, this one. So all the beams return back to the transducer. It appears very hyperechoic, but it will not pass any sound beams distal to that calcifications. So that's why will appear everything behind that one or distal to that one is completely black. This example of a tophus with many crystal loads, but the crystal load, it seems not too much load, and that's why I can't see the bone behind it. It's no acoustic shadowing behind it. So it depends on the density of the calcifications or density of the uric acid crystals in the tissue. Another kind of shadowing which can happen, or another kind of artifact, acoustic enhancement. The acoustic enhancement if the ultrasound beam pass through low attenuating structure, and this can be through a cyst filled with fluid. So this is low attenuating structure, and that's why the beam passing freely without any reflection or refraction, and it will be appearing very white and very bright, the tissue distal to the Baker cyst. How we can avoid? Why we wanted to avoid? Because sometimes we have here a tendon, suppose it is a semimembranosus, we need to see in any examination, and we need to see if there is tear or no. So I have to reduce little bit the brightness or the echogenicity of that structure here, so I can control that through the time gain control here. For the far field gain, I should reduce it a little bit. So after reduction of that one and moving from here, I can see it clearly. I can telling about the structure or the target deep to the cyst. Another kind of artifact, which depending on refraction, is the edge shadowing. And edge shadowing, that is because if I have two structures with different impedance here, like the tendo-Achilles paratenon around it, sometimes falsely diagnosed as the paratendinopathy. That is because of some beam coming in a tangential angle and refracted or scattered, leading to energy loss in this area around the tendon, and the lack of echoes returning from the wall, leading to a formation of shadow. And how we can adjust it? It's a little bit, we'll do a heel-toe maneuver just to adjust the angles of the beam, and we will check our tendon through two perpendicular plane to be sure that is it tenosynovitis. Another kind of artifact, it's related to reflection, which is reverberation. Reverberation, it's a kind of, as we see here, when we try to give intra-articular injection with a needle under guided ultrasound, sometimes we can find a lot of lines deep to the needle itself. Reverberation arises when the beam encounter too highly reflective interface, and the beam is bouncing back and forth many times between the interfaces, and the reflective waves takes longer time to be received by the transducer, and these appear as multiple parallel lines down, and the last one, after the intensity lost through the tissue of the sound, after that it will disappear. So it occurs when there is a big acoustic impedance mismatch, and it's worse if the beam is perpendicular to the needle. So we'll try a little bit to adjust our angle and not to make it in parallel. So how to avoid it? To avoid it, we have here the harmonic control. We can do it, we can press it, it can help us, or it's changing the probe, making heel to maneuver. So we can changing the angle of our probe, not to make it perpendicular to the tissue, make it little bit so angulated or different from 90 degrees. That time it will be like echo, weak echoes coming from the needle, and will be less reverberation problem. Also, we can reduce little bit the gain. Another kind of artifact is an isotropy. And an isotropy is a kind of artifact which is angle or direction generated artifact. The reflection beam is maximal where the incidence of angle is 90 degrees. And it happened to the structure of linear fibrillar structures, mainly tendons. Sometimes it happened to the ligaments, and to less extent, it can be for the nerve as well. The larger the deviation from the angle or from the 90-degree angle, the fewer the sound are detected by the transducer or reflected to the transducer. And this is the cause behind the hypoechogenicity we can find inside the tissue, which is completely normal, but sometimes we suspect it's a tear. Here is some examples of that. Like here we have the biceps tendon. Sometimes we find it hypoechogenic if we did not adjust our probe to make it perpendicular beam. And here is the tendons of the flexors of the wrist. Again, sometimes it happens with it. How we can overcome this problem? Many things. We can gently tilting the transducer, not to becoming completely perpendicular to the structure. Sometimes it's enough to move only the joint slightly, or we can make some contraction of the muscle. It's very helpful, especially for the knee. We can contract the quadriceps muscle. So at the end of the tendon of the quadriceps tendon, we see here as hypoechogenic, near to its attachment to the patella. But if we make contraction of the muscle, it will appear more bright, so we can see it more clearly. Also, we can be sure about our tendon if there is tear or no, to use in short axis and long axis. So in two perpendicular planes, we can evaluate, and also with dynamic evaluation is very important to be sure that there is no tear. Another kind of artifact, it depends on the velocity and the propagation of sound waves. I think I talk about that. We call it bayonet. It's due to refraction and changing of impedance. I talk about that previously. We have also mirror image, and how mirror image happen. Mirror image is the little bit reverse of the assumption that ultrasound wave is travel in a straight line and directly to the reflecting object and back to the transducer. The idea behind the mirror image is the beam, it's like moving or traveling in different paths, and that's why it appears a little bit delayed. What happened is we have here ultrasound beam is going down to suppose this is a bony part, and then object here. So this object here, part of the waves, it's returning back, or part of the echoes is returning back to the transducer. It make here the primary target, and after that it go around to a secondary object, strikes in that secondary object, which appearing returning back that echo, but very late. So that echo will appear a little bit deep and will appear beyond the reflector. Here is example of the extensor carpi radialis brevis and the longus in the second extensor compartment. The beam here strikes these primary objects. After that, some of the waves return back to the transducer. So the primary target, which is the extensor carpi radialis, longus, and brevis appear. And then part of the waves go and strike here a very strong reflective surface, which is the bone. So it returns back, but it takes a little bit a long journey and a long time until it reaches the transducer. So it will appear on the same plane of the extensor carpi radialis, the original one, the normal one, and the extensor carpi radialis longus, but behind the reflective surface, which is the bone. How we can avoid? We can reduce the gain deep to the reflective surface here, so we'll not see any shadow here, and we'll change the angle of insonation as well. Sometimes there is some artifacts is related just to electrical noise or related to electricity. That's maybe because of the no earth or no ground or something like that. So we change the equipment place in the room and it will appear like this shape. There is also another artifact, which is bone pseudo defect. The pseudo defect is because here it appear part of the bone. It mainly happen to the femoral condyle or appear in the elbow. Sometimes we'll find the missing here of the bone here, and we suggest that this is a kind of erosion because the beam hits the bone tangentially, and the reflecting echo failed to be detected by ultrasound, so it will appear as faint, and we can misinterpret it as erosion. But there is a big difference between erosion and the pseudo defect. The erosion is we have a floor, we should have a floor for erosion, and for sure we should detect it by two perpendicular planes. Sorry, I get stuck a little bit. I don't know why. Yeah. Another kind of artifact, which is called the cartilage interface. And the cartilage interface is a kind of hyperechoic rim. And this hyperechoic rim, we can see it in the tear, mainly for sometimes we see it most commonly in the supraspinatus tear. That is because this rim is displayed when the beam is like reflected, because it's here consider this tear part is low attenuating, and the beam passing very clearly down with reflection, so it causes interface here. And how to differentiate it between it and gout, if there is any precipitation of the crystals or the double contour sign, if we apply some pressure with our probe, it will disappear after pressure. If we do some compression or if we move the part, we will find it will be moved. And for the gout precipitation or the double contour will be fixed even with movement of the joint. Sometimes also at the beginning of our work, and we are here in a basic course, so sometimes there is some contact artifact and some skin irregularities, and this is because only of lack of copious amount of gel. So my key points today is artifact frequently occur in gray scale of ultrasound due to some physical and technical properties. Some artifacts can be avoided by modifying equipment setting and appropriate performance of the examination. And some artifacts can aid in distinguishing tissues and lesions. Certain artifacts occur in musculoskeletal ultrasound. Awareness of them are really of paramount importance. That was my last slide. And I thank you all so much. Thank you for hearing me and the attendance.
Thanks, Dr. Nasreen, for this comprehensive talk, and thanks again for being with us today. Just a reminder for our participants today, just if you have any questions, please insert in the chat box. We will have a discussion session at the end of all presentations. And we are moving forward in our program today. So our third talk was actually one of my greatest friends, Jasna. Dr. Jasna is a known consultant rheumatologist and is known president of the METUS group, Musculoskeletal Ultrasound Imaging Technique ongoing from Greece, Athens, scientific associate of the fourth department of pathology of Hippocratean Hospital in Thessaloniki, Greece. He's medical graduated from the Belgrade University, and Dr. Jasna is known with her participations in training and education for ultrasound for a long time, and also participated with well-known researches and publications on different chapters of books. We are lucky today to have Jasna with us with one of the best presentation about shoulder I ever seen about the ultrasound of the shoulder. So without further delay, Jasna, the floor is yours.
Okay, you may hear me, but as I see, you can't see me.
Yes.
Yes, so where is the problem now?
You just need to have the full screen of your slides.
Yeah. Thank you. Very glad to be with you again, not tête-à-tête, but by Zoom. Anyway, my job today is to elaborate on standardized scanning of the shoulder. That is the most common application in musculoskeletal ultrasound, along with the knee scanning, due to the high incidence of rotator cuff disorders related to aging, sport activity, and inflammatory diseases. As you know, this joint is extremely complex. It is composed of scapula, clavicle, and proximal humerus. And these three joints actually form 3 proper synovial joints and 2 gliding plans. So these joints actually allow full movement, full range of movement of this joint. Just to remind you that the shoulder joint is stabilized by a firm and thick fibrous joint capsule and stabilized by plenty of ligament. On the roof, you may find the coracoacromial and coracohumeral ligament, and at the anterior part, mostly 3 glenohumeral ligaments. The tiny transverse humeral ligament, you may see it here, spans 2 lips of the bicipital groove, holding and stabilizing the long head of the biceps tendon, along with the final fibers of subscapularis tendon. The lead tendon in this region is undoubtedly the long head of the biceps tendon. That is, again, 1 out of 2 specific tendon, as I can say, in human body, the intra-articulary along with the popliteal one. And after rising from the supraglenoid tubercle and running within the joint space, it runs outside through the bicipital groove till the myotenondial junction. It is also the only one in this region that is invested with synovial sheath. That is actually extrusion or extension of the glenohumeral joint itself. So there are pathologies very frequently mixed and intermingled. The large, huge deltoid muscle actually covers the rest of the tendon that are on the posterior side, supraspinatus, infraspinatus, and teres minor together to the greater tuberosity, while the teres major runs to the medial lip of the bicipital groove. The first 3 tendons from the posterior view, along with the subscapularis muscle, are parts of the rotator cuff. You must know that, as well as the presence of the biceps brachii, remember the long head, while the short head takes its origin from the coracoid process in a view of conjoint tendon, along with coracobrachial muscle. Let's talk about the synovial spaces, starting with the tiny proper synovial space of the acromioclavicular joint on the top of the shoulder, while under the acromioclavicular arch and the deltoid muscle is spread huge synovial space of the subacromial subdeltoid bursa. It furthermore, it actually covers the full deep part of the shoulder, along with the deeply seated glenohumeral joint and its space itself. Let's see what is happening with the glenohumeral joint. It's very complex. You see, this is a short scan through the glenohumeral joint. This is for your orientation, posterior and anterior side. At the posterior side, supraspinatus and infraspinatus muscle. from the anterior coracoid process with the conjoint on tendon and subscapularis tendon. You remember, I have already mentioned it. This green surface actually belongs to the glenohumeral joints, and it is shaped by 3 glenohumeral ligaments in few recesses. The most dependent one belongs to the axillary recess, the most important for us, the posterior one, and 2 subscapularis recesses. The superior one should be definitely differentiated from the subcoracoid bursa that is positioned in between these 2 muscles. So all these structures may be evaluated by using the ultrasound, and according to the EULAR, there are in sum 9 standard scans that allow full evaluation of the shoulder joint. As you know, we always start with the scanning of the long head of the biceps muscle. This is the position of the patient, and you always scan the whole length of the tendon, first in the short and then in the long scan. And see, either you have a study about ultrasound or not, you must have seen these 2 images. This is the short scan, the bony contour of the brachial bone, bicipital groove, short scan of the hyperechoic oval cross-section of the long head, tiny transverse ligament, and last fibers of subscapularis muscle coming from the medial side. While in the long scan, the long head of the biceps tendon is visualized as any other tendon as a hyperechoic fibular structure. So remember these 2 structures in order to see the pathology. We are still at the physiological images, normal images, and see what is happening at the video clip. You start always from the beginning under the articular capsule through the bicipital groove till the very end at the myotenondial junction. You see that is positioned under the attachment of the greater pectoralis muscle that takes its origin or ends up to the lateral lip of the bicipital groove. Sometimes in normal condition, this is the inherited condition, the patient is asymptomatic. You may find 2 slips of long head. This is a bifid long head. It's very easily visualized in the short as well as in the long scan. The most frequent pathology, and very simply to be found, is tenosynovitis. Remember, I have mentioned that this tendon is invested with synovial sheath, and it is depicted as anechoic halo that surrounds hyperechoic cross-section of the tendon in a transverse as well as in the long scan. You also have to pay attention of the bicipital groove. In this case, it's empty. However, the hyperechoic cross-section of the biceps tendon, the long head of the biceps tendon, is sitting over the eroded greater tuberosity of humerus, which means that it is subluxation of the long head, and in the long due to the continuous friction of this tendon against the eroded greater tuberosity is visualized as thick, swollen, hypoechoic, and dearranged. And again, in this case, the bicipital groove itself is wide, is shallow, and with a deep erosion on the bottom, as well as it might be found with a sharp osteophyte at the lateral lip. However, there is nothing hyperechoic in oval shape sitting anywhere in the surrounding tissue, which means that there is nowhere long head of the biceps, and this is the condition known clinically as a Popeye sign due to the complete tear of the long head of the biceps, not so rare. Oppositely, in acute condition, this is only 2 hours after the event, the bicipital groove is not empty. It is a huge distended synovial sheath of the long head, but it is fulfilled with hypoechoic to anechoic tissue that belongs to debris and blood due to the complete tear of the long head. If we proceed to the next tendon muscle, that is subscapularis one, we have to ask the patient to rotate the forearm laterally, externally, in order to pull out under the coracoid process and conjoint tendon, the subscapularis tendon itself. So see how does it look in the normal condition. This is coracoid processes and conjoint tendon. This is myotenondial junction. And then from this point, we have to evaluate the whole length of the tendon in the attachment at the lacetic surface of humerus. The frequent pathology in this tendon, in these tendons that are not invested with synovial sheath actually, is calcification, different types, size, severity of calcification, and number, of course, tiny calcification at the point of attachment of emphasis, or multiple spheric calcification, a hypercoil clump in the space of the tenondial tissue. Pathology in this tendon and in this region is very frequently mixed. So no matter how impressive looks the tenosynovitis of the long head, do not stop screening the screen, which means that you may miss the rest of pathology. And again, in this point, you will ask the patient, ignore the tenosynovitis of the long head and ask the patient to rotate or rotate it passively, externally, and see how this huge hyperechoic lump of calcification is getting in front of you in the mid space of the screen. The next most frequent pathology of this tendon definitely tears, and this is a complete full thickness tear of subscapularis tendon in the long and in the short view. You see this anechoic gap where the tendon used to be. The most important tendon of all of rotator cuff tendons is undoubtedly supraspinatus one. It will be examined in either Middleton or cross position, while the footprint of the transducer is positioned over the final fibers of the tendon in a long view. So sometimes, due to its big shape, it's almost impossible to adjust properly the angle where the ultrasound dimensionate the final fibers of the tendon. And therefore, you may see this hypoechoic final image, this small area that must be or may be pathology, but the most possible is that we are talking about anisotropy. Remember, this very frequent artifact. So the only thing you have to do is to adjust the position of the transducer by tilting the lateral pole of transducer in order to adjust the insonation angle of the final fibers. And therefore, the final fibers you see runs in different. They run in different directions, but the final one is depicted as hyperechoic and fibrillar, and this is the nice and normal image of supraspinatus tendon. And again, the most frequent pathology is calcification. This is the single one in the middle of the tendon with wide and large calcification, and there is also acoustic shadowing from underneath. But you also may find this needle-shaped tiny calcification that are completely impressively depicted in transverse view, just as a hyperechoic single shot or spot in the mid space of the otherwise completely normal tendon. And again, tears. This is a full thickness tear of the supraspinatus tendon, but see that the edges are not retracted, they're still at their point, and you also may see the communication between two synovial spaces. This is a supraomian subdeltoid bursa, this is the gap in between the edges, the rupture, and the glenohumeral space. This is long and the short scan of the tendon, and you see the communication easily in this space. And again, the full thickness tear, but in this it's avulsion from the point of attachment, and the tendon is retracted laterally, but this is a very fresh, only 1 hour event, and the shape of the tendon is still big shape due to the internal pressure of the debris and the blood, and also again in transverse view, you see communication between subacromial subdeltoid Bursa gap and glenohumeral joint. But this is the image of the patient 15 days later. You see that the debris has been resolved, and the large and heavy deltoid muscle have divided into the space of the supraspinatus muscle. Excuse me, but I believe, can you hear me? Okay. This sign is known as deltoid herniation. Deltoid herniation may be more mild because of the less reduced resistance of the supraspinatus tendon due to the smaller, in this case, the articular side of the tendon. Do not miss, of course, this irregularity at the point of attachment of the tendon. Unfortunately, frequently you see this kind of image. This is a massive tear of the supraspinatus. This is a deltoid, acromion, brachial head, and nothing in between these two structures where the supraspinatus tendon used to be. This is the old standing tear, and I can see it because of irregularities of the head due to the long-standing friction against the surrounding tissue, and therefore we may conclude that we are talking about long-standing tear. And very interesting case of this lady, but rare. I've seen it only once. She was appointed from orthopedic surgeon for the possible flare of psoriatic disease and possible involvement of rotator cuff disease. No blood test, no X-rays. You see from the start of evaluation, we may see normal bicipital groove and the cross-section of the long head of the biceps, but going laterally, there was a huge defect of the bone contour of greater tuberosity. You may see it, and this defect was much more impressive in the long view, and going posterior, there was enormous gap behind the attachment of the supraspinatus muscle. And you remember the definition that defect in body contour is actually a fracture. So this lady, this is the appearance 7 days after the event. She was appointed for X-rays, and this was avulsion of the greater tuberosity, and she was referred again back to orthopedic surgeons. What about infraspinatus muscle? It is not that important for its pathology, but it is very important for its topography. You remember I have mentioned that anteriorly to the infraspinatus muscle is positioned posterior recess of the glenohumeral joint itself. So in order to evaluate two of them, it is enough to place the transducer, the footprint of the transducer, along to the fibers of infraspinatus muscle. So this is the normal image. This is infraspinatus muscle, infraspinatus tendon, brachial head, hyaline cartilage, glenoid labrum. This is articular capsule, and here is the posterior recess. If you want to indulge accumulation of the excess fluid, if exists, you have to ask or to rotate externally the forearm of the patient's head, and if there is any excess fluid, it would be accumulated here. It's completely normal posterior recess as well as infraspinatus tendon. But see what is happening in the case of synovitis of glenohumeral joint, while from internal to external rotation, to see how the shape of posterior recess has been changed. Again, the same procedure, the same maneuver, old standing array. This is the glenoid, nowhere labrum, glenoid labrum. This is infraspinatus, and see what's happening during the external rotation. You see there is huge gap, and after the final movement, the glenoid actually gets into the gap. It's a very painful condition, and remember, this is a fracture. This is a heel sac fracture, so-called. Okay. What about subacromial subdeltoid bursa? Remember, it is spread under the acromioclavicular arch, deltoid muscle, and the rest of the shoulder, and see how huge it is. And be careful when we have problems and defect in supraspinatus tendon. This is the supraspinatus tendon. Sometimes we may see communication between all three of these synovial spaces: acromioclavicular, subacromial subdeltoid bursa, and glenohumeral space. Usually, this can at this point in between deltoid muscle and supraspinatus, and see this is the normal image: deltoid muscle, supraspinatus. Of course, here in cartilage and brachial wall. And this is the subacromial subdeltoid bursa, two leaves, the external and internal wall, and this is the capillar space. There is no fluid within, and sometimes it might be difficult to be defined. However, when the fluid is present due to the internal pressure of the fluid, two walls of the subacromial subdeltoid bursa are separated and very easily defined as well. And also you may apply Doppler signal to detect any inflammation in these walls. So sometimes palpating the region, you may find the presence of bursa. However, you may not assess the content of the bursa, and this is very important. This is very interesting one with the presence of anechoic fluid. Is most usual, but also the mild proliferation of the external wall. This proliferation might be huge, such as in this case. This is a long-standing chronic rheumatoid arthritis, and if you wish to aspirate the fluid from this bursa, it may be difficult without ultrasound. Also, talking about content, in this case, this is not anechoic. There is a space, a layer of isoechoic content that is collided to the external wall. This is a blood. This is the case of patient that who used to take anticoagulant drugs, and this is the image of subacromial deltoid bursa. 15 days later, this blood clot within the subdeltoid bursa. And just a few slides, two slides about injections. When this anechoic space or layer is present, it's very easy to be injected. So you have to find a shortest path and then to follow the track of the needle tip till the anechoic space, and then inject the cortisone, so you have completely accomplished your job and perfectly accurate. But much more difficult is definitely to inject into the dry bursa or frozen shoulder, but the procedure is exactly the same. You are going to approach this tiny line. This is the space of subacromial subdeltoid bursa, and then by injecting the fluid, you see the two walls are separate. It's very easy by using ultrasound. And do not forget, for the end, to assess the superficial acromioclavicular joints. Very easy, very accessible. It is synovial space. Said the edges of acromioclavicular are separated by fibrous disc that is interposed in between these edges, while the joint is stabilized by acromioclavicular superior and inferior ligaments. And do not forget the close proximity of subacromial subdeltoid bursa, that is exactly under the joint, as well as supraspinatus tendon. Always comparing with the normal image, you see this is the edges of acromion and clavicle, and see at this point how the acromion is sharp and steep upward due to the osteophytes, the huge osteophyte, while the acromioclavicular ligament superior one is bulged upward. In this case, again, the acromioclavicular ligament is bulged, but it is protruded disc with chondrocalcinosis. These are CPPT deposition within the fibrous disc. And for the end, this is the last scan, this axillary scan. It might be painful, but you have to scan it in order to assess the axillary cells that is found nearby the humeral neck. This is under the triceps muscle, and if present, this recess is bulged. So before I thank you for your attention, I have to remind you the two forthcoming intermediate courses, the course in Dubai in October and in Athens in December. So at this point, I will thank you for your attention.
Thanks, Jasna, for the nice talk as always, and thank you again for being with us. So we are moving forward. Just please insert your questions in our chat box, and we'll get back to all the questions after the last presentation. So it's my great pleasure actually to introduce our fourth speaker for today. My brother, Dr. Mohammed Murtada, is a full professor of rheumatology, rehabilitation, faculty of medicine, Zagazig University. He's currently the head of musculoskeletal ultrasound unit at the Faculty of Medicine, Zagazig University, and already a known member of the OMREC ultrasound group with well-known publications participating in the field of ultrasound and rheumatology, over 85 published publications between published abstracts, studies, and full manuscripts and book chapters. And he's well known also about his participations in training in the ground field of Egypt and also in our region. Dr. Murtada will give us a talk about the basics of the elbow ultrasound scan. Dr. Murtada, without further ado, thanks to us, and the floor is yours.
Dear colleague, thank you for very much. It's my pleasure to be with you all. I want to thank Professor Ahmed Abu Gamal and all the board of Emirate Rheumatology Academy for their kind invitation and for conducting such a perfect activity. Really a great effort. We will talk about musculoskeletal ultrasonography of elbow. This is my agenda. I will talk about the indications of ultrasonography in elbow joints, then proceed to anatomical landmark of elbow and the standard scanning position, and then sonoanatomy and some of pathological finding by ultrasonography. Why we do ultrasonography for elbow joint? First, to detect effusion and synovial proliferation. For in rheumatology practice, this is very important, and detect synovitis and bursitis and some of bony lesions such as erosions and or osteophytes. Sometimes we need to know if there is a loose joint bodies, and it is important to differentiate differentiation between gout, tophi, and rheumatoid nodule. And the most common finding is tendonitis at the medial or lateral epicondyle, and sometimes we found calcinosis. And lastly, but not least important, is tendon rupture. First, we'll talk about the anatomical landmark of the elbow. Elbow joint is a complex hinge pivot joint with three articular components. The ulnohumeral joint between the ulnar trochlea notch and the trochlea of the humerus, and the radiocapitellar joint between the radial head and the capitellum of the humerus, and the proximal radio-ulnar joint. These are the anterior view of the bones of the elbow joint. Here's the humerus, and this is the radius and ulna, and this is the posterior view where the olecranon and olecranon fossa and radial head. For anatomical, this is the muscles. From the anterior view, it will appear like this. This is the biceps tendon, just in the front. In the back, there is the brachialis tendon, and more lateral extensor carpi radialis and the pronator teres. The lateral view of the muscles will show the lateral epicondyle attached to it the common extensor tendons. Extensor carpi radialis brevis, extensor digitorum and anconeus, and extensor carpi ulnaris. This is the common extensor tendon. We will see by ultrasonography. From the medial side, you can see the medial epicondyle and the ulnar collateral ligament and the common flexor tendons, flexor digitorum superficialis and the flexor digitorum profundus. From the posterior view, this is the triceps tendon, and on the back there will be the triceps muscle itself. So the tendon and its muscle. And there may be the extension of the tendon. These are what are the standard scanning positions? These are the patient should sit in sitting position with full extension of the elbow for anterior examination, and the flexion of the elbow joint in at 90 degree for lateral and posterior evaluation, and May 45 for medial evaluation. We use usually linear probe for the machine and high frequency probe 10 or more megahertz. These are the standard scanning position: anterior humeroradial and the humeroulnar longitudinal scan, anterior transverse scan, medial longitudinal scan, lateral longitudinal scan, and posterior longitudinal and transverse scan of the olecranon fossa, longitudinal scan of the sulcus ulnaris, and transverse scan. So you use usually medial and longitudinal and transverse scan for anterior, posterior, and even for the ulnar nerve. But for medial and lateral scan, usually we use mainly longitudinal scan. This is the anterior humeral longitudinal scan. This is the position of the patient sitting with external rotation, with palm up and elbow extended, and we put the probe humeroradial and humeroulnar. This is the humeroulnar. So in this way, this is the ulna, and this is the radius, and this is the humerus. The same here, and from this is the bone. This is the brachialis and biceps. For humeroradial, this is the same position, but we put more lateral. So we find the radial head and the humerus. This is the two scans in the humeroradial and humeroulnar to see the difference. Just there is the bone. The shape of the bone is changed, but according to the shape of the humerus, the ulna or radius, but in the same, in the front, in the anterior view. And above there is the brachialis and the biceps. On transverse view, we will see wavy cartilaginous part of the trochlea of the humerus, like this, and usually jet black, as there is a cartilaginous layer. Then in the brachialis, and this is the biceps tendon, just small, round, and oblique, and medial to it there is the artery, the biceps artery, and the nerve, median nerve. This is the bone, this is the trochlea, above small layer of cartilaginous layer, and this is the brachialis muscle, and this is the biceps tendon, and this is the artery, and this is the nerve. Another view. For the medial longitudinal scan, we can see, we can bend the 45 or degree flexion of the elbow in this position, and we see the medial collateral ligament and the common flexor tendons. This is the bone, this is the medial epicondyle, and this is the common flexor tendon, and this is the ligament. This is another view, the same medial epicondyle, tendon, and the ligament. For the lateral longitudinal scan, we may do a prayer-like attitude with the palm, with in this way, with the finger, with the first finger upward, and we put the probe here. We will see the common extensor tendon. It is difficult to see the lateral collateral ligament as it's the same equal textures. So we see only the common extensor tendon. Here is the lateral epicondyle, and there is the synovial recess, but this is the tendon. All of this is the tendon. I want you to know or to see that there's no hypoechogenicity and the normal fibrillar pattern of this tendon. For the posterior view, you will may pose the patient like this at this position, and you will see the olecranon and triceps tendon. And this is triceps muscle. This is the triceps tendon, and this is the triceps muscle. You should extend your vision to the distal part of the triceps tendon to detect any pathology. In the same way, you should do posterior transverse scan. Here is the fat pad, and this is the triceps tendon here, and this is the triceps muscle. If there is any effusion or synovitis, will appear here, as we will see later on. So now we end our sonoanatomy with the standard scans, and we know that we use linear probe, relatively high frequency probe, more than 10 megahertz, and we use anterior scan, longitudinal and transverse, and posterior scan, longitudinal and transverse, and we use medial and lateral longitudinal scans. What are the pathologies that we can detect by ultrasonography in elbow joints? First, we can detect synovitis, and synovitis can be defined as abnormal hypoechoic or hyperechoic intra-articular tissue that is non-displaceable and poorly compressible and may exhibit Doppler signals. One of the best ways is detecting synovitis in elbow in the posterior recess. Here, as you see, this hypoechoic area with high Doppler signals. This is normal. This is a normal view. Here, hypoechoic, and there is Doppler signals. Synovitis can be also detected from anterior scan. As this is a normal finding. This is a normal joint, no hypoechoic area, and this is fat bad. And here there is hypoechoic area in the anterior recess. Another photo. This is the normal, and this is hypoechoic area as the posterior scan. Posterior synovitis with some Doppler activities. Posterior scan. Here, anterior scan. This is the normal. Here, this is hypoechoic abnormal area in the anterior scan show synovitis. Another way, another photo, synovitis from the anterior scan. Another one, the same, another. So, what about bony lesions? Bony lesions may be erosions or osteophytes. Bone erosions as defined as an intra-articular discontinuity of the bone surface that is visible in two perpendicular planes. Here, so this discontinuity, this is erosion, typical erosion of rheumatoid arthritis. This in two planes, this is discontinuity and this way. So this an erosion. Degenerative arthropathy or osteoarthritis of elbow. Osteophytes are defined as cortical protrusion seen in two ultrasound planes. Here is the joint, this is the bone, and this step up is osteophytes. This is the normal, and this abnormal step up bony lesion is osteophyte. So now we see synovitis and erosions and osteophytes. What about soft tissue lesions? Lateral epicondylitis is the most common finding in patients with elbow pain. Lateral epicondylitis can see as a focal areas of low echogenicity, hypoechogenicity. This is the normal view as we know before. Here, there is hypoechoic area and increased thickness. So the main finding is hypoechogenicity and increased thickness and the loss of normal fibrillar pattern of extensor tendon. This is a more obvious one. Here, hypoechogenicity, increased thickness, and the loss of normal fibrillar pattern. Sometimes Especially in seronegative arthropathy, we can see Doppler activities in lateral epicondylitis. Medial epicondylitis is the same finding, thickness with hypoechogenicity, but at the medial side at the common flexor tendon. Olecraneum Bursa. This is an important finding and easily detected clinically, but ultrasonography confirmed diagnosis and can help in aspiration. Sometimes we find the activity, body Doppler activity. What about cubital tunnel syndrome or ulnar nerve? Ulnar nerve area more than 7.9 millimeter at the level of epicondyle has been indicated as the threshold value for cubital tunnel syndrome. So this is the normal ulnar nerve from longitudinal scan and the transverse scan. We detect the cross-sectional area of this nerve. This is a longitudinal scan. See this, how much it is swollen, large thickness, and we detect the cross-sectional area, especially in transverse view, and if more than 7.9 millimeter, it may indicate as a cubital tunnel syndrome. These are the most common finding, pathological finding in elbow joints, and I want to thank you all for your kind listening.
Okay, thanks, Dr. Murtada, for the nice presentation describing the elbow basics anatomy and some lesions there. So we are moving to our last speaker today. We have our friend, Dr. Basant Nadi. Dr. Basant is a professor at Banha University Hospital, Egypt Rheumatology Consultant at Al Hada Complex, Armed Force Complex. She's a large certified musculoskeletal ultrasound trainer, and she's expert in the ultrasound training and with expert degree from Barcelona University as an active GRAPPA member of the RR Musculoskeletal Ultrasound Group, certified professional healthcare quality, CBHQ, and principal author in many of research articles, abstracts, and published manuscripts in international journals. Dr. Basant will share with us a nice presentation regarding the wrist hand region. So without further ado, so Dr. Basant, the floor is yours.
Thank you, Professor Ahmed Gamal, for the presentation. I'd like to thank the organizing committee for the kind invitation. And today we will elaborate more about wrist and hand ultrasound. Just have a technical issue to share my presentation.
Okay, so you need any support?
Yeah, a minute. Am I sharing my screen now or still? These are my disclosures. I will walk you through my learning objectives for today. We will illustrate the standard scan checklist, scanning technique and sonar anatomy, and finally the common pathology in ultrasound. Why the wrist and ultrasound are important for us as a rheumatologist. You can assess more than one joints, nerves, periarticular structure in the same setting. It's a sensitive tool which can add on to your clinical exam, more sensitive than X-ray to assess structural damage. It's a static dynamic in the same session, scoring assessment to evaluate your treatment protocol, add more accurate guided intervention, as you know, faster bedside, non-invasive, and low cost. So before start scan the wrist and the hand, you should know some key points. First, these structures are superficial. So as discussed by Professor Ahmed Gamal, you need to have a high frequency transducer, so 15 megahertz or more. You need to have the patient set comfortable as well as you. And the examined part resting on a table or a pillow with the hand facing up in case of palmar exam or down in case of dorsal exam. According to EULAR, there is some scanning checklists you should elaborate during doing your volar and dorsal scan for both wrist and hand. You need to do the scanning technique, longitudinal and transverse for the same structure. For the rest, you need to assess in the volar aspect, the carpal tunnel and the flexor tendons. You should also in the dorsal aspect assess the extensor tendon compartments as well as the distal radio-ulnar joints. For the hand, in the volar aspect, you need to assess the extensor tendons. In the dorsal part of the hand, you need to assess the extensor tendon and the extensor hood, as well as the ulnar collateral ligament of the thumb. For the volar aspect, you need to assess the flexor tendons, the Bolus system, and the assessment of the joints as well. For the scanning technique and sonoanatomy of the wrist, this cartoon can summarize the structures in the wrist joint, same as this ultrasound image. You should start by bony landmark, like here in this image, the scaphoid tubercle and basiform. On top of the scaphoid tubercle, you need to assess the flexor carpi radialis on top, flexor carpi ulnaris on top of the basiform. The arrow's head denoting here the extensor flexor retinaculum. Underneath, there is a honeycomb-like structures representing the median nerve, the flexor tendon underneath, flexor digitorum superficialis and profundus, and the flexor pollicis longus towards the radial aspect. Don't forget to assess the ulnar nerve and ulnar artery in the Gyn canal. Moving more distally, you can find the two bony landmarks, the trapezium and hook of Hammett, with the arrowhead here representing the flexor retinaculum, and the median nerve underneath with the flexor digitorum superficialis and flexor digitorum profundus and flexor pollicis longus within the canal. As standard rule, you need to assess the carpal tunnel and the volar aspect of the wrist in longitudinal and transverse. To assess transversely, we need to assess longitudinally. So here, the hypoechoic superficial structure represented by this asterisk is the median nerve underneath the both tendons, flexor digitorum superficialis and profundus. For the dorsal aspect of the wrist, you need to identify the 6 extensor compartments. Starting with the first compartment, you will ask your patient to put your hand between pronation and supination with the radial aspect facing up to assess the abductor pollicis longus and extensor pollicis brevis. Don't forget to sweep your probe proximally to assess these tendons at the site of intersection, which can mimic decurvance syndrome with wrongly diagnosed. Moving more ulnar side, you will find the extensor carpi radialis, longus and brevis, with the common and most important bony acoustic landmark is the Leicester tubercle, which separates the second compartment from the third compartment. The third compartment containing the extensor pollicis longus. Then you will find the extensor indicis, extensor digitorum. At the site of radio-ulnar joint, you will find or address the extensor digiti minimi. Ask your patient to move a little bit towards the radial side and move your probe towards the ulnar side to assess the final compartment, the 6th compartment containing the extensor carpi ulnaris. These 6 compartments should be assessed again in longitudinal view for any abnormality or to confirm any pathological finding into perpendicular plane. One of the most common longitudinal assessment for the wrist joint is the median wrist joint assessment to assess any abnormality or effusion related to inflammatory arthritis, radiocarpal or intercarpal. So you will assess the radioleonate recess for any fluid, abnormal fluid, and leonocapitate recess for any abnormal fluid and arthritis. Dynamic scan for the radio-ulnar joint is essential, specifically for inflammatory arthritis. You will ask your patient to do flexion and extension while doing scanning of the radio-ulnar joint from proximal to distal for assessing any abnormal fluid or joint disruption, as in case of rheumatoid arthritis or other inflammatory arthritis. Another important dynamic scan for the wrist for assessing ligamentous disruption. One of the common ligamentous injury is the scapholunate ligament. You will ask the patient for slight flexion with ulnar rotation to check any disruption in the fibrillar pattern of this ligament. So moving to the hand, well, as you all know, the hand is a complex structure. There is a complex extensor and complex flexor tendons. So in case of the extensor part of the hand, we have the extensor tendon moving with reinforcement of the capsule, radial and ulnar side, forming the radial sagittal band and ulnar sagittal band. These reinforcements help to stabilize the tendon in place while moving the digit. This extensor tendon will insert with the central sling in the middle phalanx and 2 lateral sling in the base of the distal phalanx. These structures forming the extensor hood. Another complex structure for the flexor tendon, you should know that the flexor tendons of the hand is covered by the flexor sheath. However, the extensor tendons does not. The extensor tendons are having a paratenon. However, the flexor tendons surrounded by synovial sheath, this sheath enhanced in certain area, forming the Polis system to stabilize the tendons in place while flexing and extending. The Polis system are essential for maintaining the tendon in place. However, the crochets are important to maintain the vasculature during flexion and extension. So moving back to scanning, so this is the longitudinal scan of the dorsal aspect of the MCB joint. You can appreciate the joint capsule, the cartilage, and the recesses in case of any arthritis, and the extensor tendon with the fibrillar pattern on top. Another way for examining the cartilage in flexion to assess the cartilage, and even you can measure the cartilage site. Dynamic scanning for the MCB joint is essential to assess rupture of the lateral sagittal bands, radial or ulnar. This patient has a third MCB dislocated extensor tendon due to ulnar rupture sagittal band. So here you can find some fluid, some synovial hypertrophy, and the tendon a little bit medially subluxed in case the scanning is done while the patient extending the hand. So ask the patient to flex the hand and follow the tendon. You will find the tendon dislocated ulnar side, denoting rupture of the ulnar sagittal band. So moving more distally, you will find the slit shape joint of the PIP, and on top you can find the extensor tendon with the underlying capsule, longitudinal and transverse. And finally, you can assess the DIB, distal interphalangeal joints, for enthesial attachment, for the joint space, and for the nail to assess the lamellar pattern of the nail, any abnormal in echogenicity, or a Doppler signal related to the nail. So we'll ask the patient to move the palm up to scan the palmar aspect of the hand. Start with the MCB joint. You will find enforcement of the capsule on top of the cartilage of the MCB joint. This reinforcement of the capsule representing the palmar plate, which allow attachment for a lot of ligament in the hand to maintain tendon stability. On top, you will find the flexor digitorum superficialis and profundus. You cannot identify which of which unless you have a pathology, and the small sac hypoechoic-like structure representing the A1 pulley to allow stabilization of the tendon in place. So here again in the transverse place, the palmar plate, the tendons, superficialis and profundus, and the hypoechoic surrounded structure representing the pulleys. So this 3D image can help us to understand the insertion of flexor digitorum superficialis and profundus. So the flexor digitorum superficialis end with two slings, which inserts into the middle phalanx. However, the flexor digitorum profundus passes through these two slings to be inserted at the base of the distal phalanx. So in such cases, you can assess the insertion, the distal emphasis, you can assess the tendon integrity, you can assess the joints and palmar plate. So this is the continuous line representing the sling of the superficialis inserted in the middle phalanx. However, the dotted lines, which continued up to the base of the distal phalanx, representing the flexor digitorum profundus. Don't forget to assess the joints and palmar plates. The lateral scan is essential to identify erosion, specifically in the MCB 1, 2, and 5, and the lateral aspect for the PIB and DIB joints. Don't forget to scan the thenar and hypothenar muscles for superficial and deep muscles. And one of the common structure in the thenar muscle to be affected is the flexor pollicis longus, should be scanned longitudinally and transverse. Finally, I will elaborate some common pathologies in ultrasound of the hand and wrist. We have a long list, and the pathology can be detected in hand and wrist. Effusion, as discussed by our colleagues today, it's a compressible, displaceable, showing no Doppler echoes. However, the synovitis, it's hypoechoic, poorly compressible, poorly displaceable structure that exhibits some Doppler echogenicity representing active inflammation. A hypoechoic structure surrounding the tendon. This is the fourth compartment of a patient having tenous synovitis, and you can appreciate the transverse hypoechoic structure surrounding the tendon, transversely and longitudinally exhibiting Doppler echoes denoting active inflammation. Discontinuity of bone representing an erosion and should be confirmed in two perpendicular plane, and please don't mistake erosion with the step up defect representing osteophytes. And despite being rare in the hand, however, in patients with aggressive tophaceous gout, you may appreciate hyperechoic aggregates in case of tophaceous gout. Don't forget to assess the nail. This is the normal nail, trilamellar pattern with normal echogenicity of the nail bed. And this is the normal Doppler exhibition in such normal population. However, patient with psoriasis and psoriatic arthritis, you may appreciate thickening of the nail, as well as hyperechogenicity and thickening of the nail bed with more Doppler exhibition. Subclinical synovitis and enthesitis in psoriatic arthritis patient can be assessed with ultrasound and can predict the evolving psoriatic arthritis in the future. This is a study done in our institute. Another study in our institute to assess the carpal tunnel syndrome with the ultrasound, and 2.5 millimeter square difference between the cross-sectional area distal and cross-sectional area proximal at pronator quadratus could be used as a diagnostic value for carpal tunnel syndrome. This is the cross-sectional distal in a patient with carpal tunnel syndrome, and this is the proximal part at the pronator quadratus in the same patient. Hypoechogenicity and V sign could be a part of the carpal tunnel syndrome, and some patients may exhibit Doppler signal at the site of inflammation. Microcalcification is the ultrasound is more sensitive to detect microcalcification in spite of being absent in X-ray in a patient of CBBD or pseudo-gout. So my home messages for today: ultrasound offer high fidelity imaging. It can assist the treatment monitoring, guide your accurate intervention. My advice for today: train yourself on normal individual before starting to detect pathology. With proper machine setting, background artifact, and bitful knowledge, you can have a refined diagnosis and the exclusion of the concurrent pathology. Thank you.
Thanks to Basant for a nice presentation as always. And now inviting all the speakers to just join us in the board here when open their camera. We have a short discussion from the attendees. So I'd actually like to thank you all for being with us today with nice presentations. And let's check for the chat box for questions. Okay, we have a couple of questions from. We have a question from Umayma. She's asking how to differentiate between hypoechoic structures. Is it by anatomy? So, what do you think, Jasna, with this question?
I'm sorry, I'm not sure that I have understood the question. The question was if the structure shows hypoechoic.
Yes, if you have hypoechoic structures, how you can define it it is in comparison to the surroundings or by the anatomy or by the structure itself?
Yeah, first of all, it is mandatory to know anatomy perfectly, especially topographic anatomy. And thereby you may assume if there is any structure that should be found there, hypoechoic, I mean muscles or nerves in a cross-sectional ways, talking, and after that, if there is something, and of course you must know the normal ultrasound image. So by combining the topography and normal ultrasound image, if you see something different, then we may talk about the proper, real hypoechoic image or anisotropy, for example. If you know that somewhere should be found the cross-section of a tendon or something that might be hyperechoic, you may tilt the transducer to try anisotropy. And in a different way, if there is nothing happen, which means that there is nothing there and you can't fix the anisotropy, probably there is a kind of pathology. But definitely it is mandatory knowing perfectly anatomy for using an ultrasound.
Yes, I agree. You have to understand the normal structures. You have to understand about the pathology and anatomy. It's a combination of all this information together. So the second question is about, this for me, about the anisotropy. We mention always the biceps tendon. Yes, actually, anisotropy by definition, it's about the relation between the foot plate and the long axis of examined structures. This is the relation. We always refer to biceps tendon, yes, because the tendon natural course is usually not parallel to the foot plate of the probe. That means that you always have to show some anisotropy in the biceps tendon. But anisotropy could happen with any structure with longitudinal fibers or parallel fibers, as long as it is not parallel to the foot plate of the probe. You still have the chance to get anisotropy, either it is biceps tendon or even another tendon. The third question from Amal Fahir asking what is the specifications minimal ultrasound machine to perform ultrasound in common lesion in practice? Murtada, what do you think?
This is a good question. We need a high quality machine. First of all, there is a rule that we should invest more money in learning than in the machine. But the machine is still important, so we need machine from 10 to 18 megahertz. May 15 can detect most of the pathologies, but 18 I think will help more. But less than 10, I think it doesn't work. In fact, we need the linear proof. If you have fingerprint proof, it is better. But according to the budget, linear proof sometimes many times it enough. Curved probe, it is rarely used in rheumatology. So if we, according to the budget, if you have more frequencies or more probes, it's better. But at least you should have linear probe at least 10 to 15 megahertz. This is my advice.
Okay, thanks, Murtada, for the common questions. It's, from Higazi, senior. Can anisotropy help to differentiate between nerve and tendons, Dr. Nisreen?
Yeah, it can help, but to a lesser degree, nerve also can cause sometimes an anisotropy. But I know, during our learning at the beginning of ultrasound, yes, it can be. Tendon is the most linear structure which can cause an anisotropy. And I think a nerve is less. It can cause also an anisotropy, but less than the tendons. Okay. For sure, he should actually check the tendon itself in two perpendicular plane, in short axis view, and also in longitudinal view, just to be sure that is it any tear in the tendon or not.
Okay, thanks. We have a question from Shrakawa. He's asking for aspiration. Does there is a measurement for synovitis, or just if the effusion is large, we can aspirate it? I think the question about the mixed lesion, if you have the synovitis with effusion, is there a certain measurement for synovitis, or just insert your needle and aspirate? What do you think, Basant?
Aspiration usually used as a diagnostic tool for assessing the inflammatory arthritis. You may use the aspiration as a treatment if it is a tense effusion. So at that time, it helps to relieve symptoms, as well as we will use the aspirate to assess for inflammatory versus infectious disorder. So it can help. There is no limit for the aspiration. You may aspirate a little amount of fluid to diagnose your patient, to rule out the septic arthritis. So there is no specific measurements to aspirate. In case if you need to diagnose, you will aspirate whatever the fluid amount. This is number one. Number two, you should differentiate, is it a fluid or is it synovitis or synovial hypertrophy? So if this hypoechoic structure exhibiting Doppler signal and non-compressible, non-displaceable, so this is a synovial hypertrophy, it will not be aspirated. And at that time, inserting the needle will not help. So you should differentiate first. And if the amount is tense, you may help the patient by aspiration, and you need the fluid for assessing the diagnosis, ruling inflammatory arthritis, and differentiate from septic arthritis.
Yes, as long as there is swelling, especially for monoarthritis or even unclassified arthritis, insertion of the needle is the answer of the question. Question for Murtada regarding the elbow. When there is a limited range of motion of the elbow joint in RA patients, what are the expected findings with ultrasound? And if it is possible to see effusion when there is no clear swelling in clinical assessment?
When there is limited range of motion, you still have the posterior scan. It's easy, and you don't need a lot of flexion or extension. On usually posterior scan is a good window. Lateral scan also available to detect synovitis. The other question, what?
If there is no clinically felt effusion, it is still a possibility to see effusion.
Yeah, so this is the rule of ultrasonography. Yes, many times.
That's why we ultrasound.
Yes, yeah.
Okay, we have a question from Ibrahim Fauzi about how we detect the area of proximal and distal dissection, I think, intersection of extensor tendons of the wrist and the hand.
So the area of intersection, usually it is 4 centimeter proximal to the first compartment at the wrist joint. And at that area, you will have the crossing of the first over the second over the first compartment, which may elaborate a pain for those patients and misdiagnosed as de-Quervain syndrome. So you should follow the tendons from proximal to distal, and while following these tendons, you will find the crossing of the second compartment over the first compartment, and if there is inflammation or loss of the fibrillar pattern hypoechogenicity at that site with normal first compartment, this denoting intersection syndrome.
Okay, Basant, did you think there is a differentiate? You can differentiate between synovitis in gout and RA in the rest of the hand?
Synovitis in the rest between gout and rheumatoid arthritis.
This is another question for you, yes.
Usually it will be showing synovitis unless we have an aggregates but usually it will be in the MCB joints rather than the wrist joint. I did not see aggregates in the wrist. I usually saw these aggregates or tophi at the site of the MCB and PIPs. So in such cases, yes, you can differentiate.
Okay, based on the supporting finding, but synovitis itself, you cannot differentiate.
You cannot differentiate synovitis itself.
Yes, for sure. Philip is asking about, first, thank you all for the wonderful lectures. And he asking if we can repeat about the double contour sign from hyperechoic artifacts in the cartilage in patient with gout. I think he's asking about the cartilage interface sign and the double contour. Basant, Nasreen, if you can help, please.
Yeah, for the double contour sign, it's something like precipitation of the superficial layer of the cartilage. Normally, it's a hypoechoic, the superficial layer of the cartilage. It's very after a crystal load, or in the case of gouty arthritis, there is precipitations of the crystal in the superficial layer. So it makes like a parallel line, parallel to the bony parts down to the cartilage. So we can see it like a double contour sign. So it means like as if we have a pencil and we draw a parallel lines around the hypoechogenic cartilage. We can differentiate between this and the cartilage interface by moving the joint. If we moving the joint and the double contour sign is still there and they persist, it means that really it's a double contour sign. Sometimes there is some reflections of sound. It makes similar to the double contour sign, but it's not the case. Once we move or once we make a pressure with the transducer, it will disappear. But the cartilage interface, this is happen in the supraspinatus tendon tear because it's an area of hypoechogenicity there, and there is some fluid in between the fibers because of tear. So it's area of what we call low attenuating for the beam to pass. So it pass and it reflect to the transducer. So it make little bit hyperechoic, very thin line on top of the cartilage. We call it interface. And if we do compression with the transducer, it will disappear.
Okay, thanks, Nasreen. So the answer is always you have to move your probe. If it is still fixed, the possibility is high for double contour. If it is not, it's double face. Usually the interface sign usually in the middle of the probe, not in the periphery, but for the double contour, it can be anywhere, either in the center or on the periphery.
Can I add something about differentiation between gout and rheumatoid arthritis in synovitis?
Yes,
I think synovitis in gout usually hyperechoic, and this is and many times there is crystals. If in a known patient with gout, usually in wrist or hand, not the first sign of gout, but in a known patient of gout with hyperechoic synovial proliferation and many crystals, and maybe double contour signs, it will favor gout. So this is
and always, as we are speaking in the basic course, always look for the clinical scenario and supporting evidence, and don't get diagnosis from ultrasound alone. This is my concept. Okay, so for Emmanuel Rageh asking about encephalopathy or ultrasound, we can differentiate degenerative and inflammatory. This is hot questions. Everybody needs to answer these questions. Actually, based on the last OMRACT update, we have some lesions related to the active acute inflammation, either tendon echogenicity, hypoechogenicity, or thickening at the tendon with positive Doppler signals. It's related to inflammatory acute encephalopathy. If you have calcifications, bone erosion, esophyte or osteophyte, this belongs more for the chronic lesion of syndesmophyte or degenerative encephalitis. But unfortunately, you can see both in long-standing inflammatory encephalitis. But this actually is all the clues about the inflammatory and the degenerative. So I'm asking about the special type of probe. I think Muhammad answered this before, that we can use a small food plate probe. Higazi asking again about the diagnosis and degree of carpal tunnel syndrome by cross-sectional area. What do you think, Basant? Questions for you.
The issue, the cross-sectional area, as differs between gender, between ethnicity. So there is a lot of study related to cross-sectional area and differs between ethnic group to other ethnic groups. Some study denoting more than 11, more than 9, more than, so it's variable. So the issue, you need to have a standardized measurement to compare to, and this is what Closer did in his study. And we did the same technique of Closer's in our population, that we measure the cross-sectional area in the distal part of the carpal tunnel in comparison to a standard area, which the median nerve at the site of pronator quadratus. So at pronator quadratus, no compression, so it could be a standardized for the same patient. So we measure something related to a standardized measure for the same person, and by subtraction of these measurement, the cross-sectional area distal from proximal, we have a value, and this value can give us a final diagnosis for carpal tunnel. So in our population, 2.5 millimeters square or more difference is considered diagnostic for carpal tunnel, and it correlates as well with the severity of the disease.
Okay, I have a question here about the synovitis in healthy individual. Yes, you can say it. We are frequently saying as a mild synovitis, could be always there, especially with old ages. Is there a specific time you should stop anti-inflammatory before assessing synovitis prior to assessment with ultrasound? No definite answer. Actually, anti-inflammatory usually could decrease the inflammation or the edema, but for synovial proliferation, it's not changeable by the NSAIDs or anti-inflammatory. Could also affect some parts of the Doppler signal, but not significantly. So there is no guidelines to stop this anti-inflammatory before the ultrasound scans. We have questions for Jasna. If there is a specific differentiation between the TB synovitis and other synovitis, Jasna?
May you repeat between?
Is there a specific finding in tuberculous synovitis with ultrasound? Tuberculous synovitis, TB.
TB synovitis.
Yes.
I must say I don't know about what point anatomically.
Tuberculous infection of the.
I see. I believe that this is not a question for basic, basic course. Yes. But you know, the tuberculous synovitis or infection or inflammation are relatively difficult. I mean, the ultrasound is not the most proper mean to diagnose ultrasound. I would refer the patient to MRI. I don't know, because the tubercle are bony surface, there are a lot of inflammation in encephalopathy at this point. Encephalopathy is easy, but if we are talking about inflammatory in a meaning of septic or something like that, if I understood well your question, it is not the most proper way to diagnose the inflammation.
Okay.
By using an ultrasound, I don't know if I got your question properly.
Yes, yes. For AC joints just now, what's your preferred technique for ultrasound guided injection, either in plane or out of plane?
It depends on the point and the size of inflammation, but in plane for me is much easier. But it is also possible as for any other space, but it depends on the point of indulging of the greatest infusion, if there is any. The most frequent reason to inject or aspirate AC joint is graded sign. You know, because of the communication of all the synovial spaces I have mentioned in my lecture. I mean, when the fluid practically from glenohumeral joint through the subacromial subdeltoid Bursa bulges to the acromioclavicular joint, the inflammation, the separate inflammation of AC joint never was the point of injection of aspiration for me. Till now, I don't know. In a few years, who knows? And usually, but the problem is that in this case of the Geyser sign is that the fluid is very thick. And you have to need it might be painful for your patient.
It's usually painful.
It's usually, yes, of course it is.
Okay. Question for you, Murtada, about from Abdulatif Al-Arfag from Saudi Arabia, asking, what do you think about discrepancies between reporting enthesitis and from radiological side reports and rheumatology side views of enthesitis?
This is
it's a big problem, actually.
Yes. I think enthesopathy was a part of rheumatology practice. I think many of our colleagues in radiology don't know a lot about enthesopathy, I think, in my practice. So we do in rheumatology, in UMRAT and GRAVA and in rheumatology community for ultrasonography, we did a lot of, we have more specific finding for enthesopathy. So I don't think the reporting of enthesopathy in rheumatology practice is the same for radiology. I think this is the area specialized for rheumatology. I don't know this will make a problem with the radiologist or not, but this is my feeling. Can I add something about septic arthritis?
Yes, okay. Well, not about septic, it was about tuberculosis.
Yes, tuberculosis and septic in general. I think ultrasonography can give a picture suggesting of septic arthritis by a high degree of effusion, high degree of synovial proliferation, and a high degree of Dopplers, and a lot of debris, inflammatory debris finding. This is not specific, maybe an activity of arthritis, but in a specific clinical situation, it may should be us by helping aspiration and sent for the lab to detect if there is any infection, including tuberculosis. So I don't think we can exclude septic arthritis. By
yes, we can say it is a high risk or low risk for infectious arthritis. Also, I do agree on this part, especially I have to finding always seeing among my patient with infectious arthritis is the subcutaneous edema. It's always there in ultrasound, and also there is inhomogeneous or heterogeneity of the synovial proliferation. You feel the synovial proliferation is not homogeneous like in other inflammatory arthritis. This is actually my clues about infectious arthritis. Our last question today from my brother Atif Kamar about the elbow again for you, Murtada. What do you think about the role of ultrasound in ulnar nerve subluxation of the elbow? I know the cause of this question, but I need the answer from you.
The ultrasonography is very excellent in detecting subluxation. Need dynamic assessment. You put the probe in transverse plane on the ulnar nerve, and this do dynamic scan by extend and flex the elbow. If the ulnar nerve jump to the epicondyle or move more than the epicondyle, it is subluxated, and there are degrees. I don't mention this in my lecture as is basic, but
Yes.
but it's a very nice fish.
So I really enjoyed the discussion with you, all my friends here, and actually I'm very proud that already I can gather you in this such a great meeting. And thanks again for the Emirates Rheumatology Academy for gathering all of us today. Thank you, Jasna, Nisreen, Basant, Murtada. Always happy to seeing you. I hope next time we can see each other face to face. And thanks for our fantastic attendees for the great questions, and be with us for tomorrow. We have also a second session covering the other parts of the lower limb, was also another big group and good speakers. Thanks again for all of you, and see you tomorrow, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.
Thank you.